Hello class, my name is Judy Cortez. Today you will be watching a quality improvement video about awake prone positioning for non-intubated COVID patients. This course is intended for the nurses of step-down unit and tele unit. The learning objective for this lesson is for the step-down unit and tele nurses to understand and incorporate the process of quality improvement in implementing awake prone positioning in the respiratory management of COVID patient with adult respiratory distress syndrome. Let's start by defining what is quality improvement. Quality improvement, as defined by Quality and Safety Education for Nurses, is the use of data to monitor the outcomes of care processes and use of improvement methods to design and test changes to continuously improve the quality and safety of healthcare system. Quality improvement is also a systematic and coordinated approach of improving the delivery of care to meet patients' needs. It involves the use of improvement model and tools to bring about measurable change. It is a continuous process of measuring, testing change, remeasuring, and applying change. Now let's talk about model of improvement. Model of improvement is a tool to accelerate improvement in projects. It answers three fundamental questions that are essential for guiding improvement work. Number 1, what are we trying to accomplish? Number 2, how will we know whether a change is an improvement? And number 3, what changes can be made that will result in improvement? PDSA, or Plan, Do, Study, Act, is a shorthand for measuring or testing change, carry out the test, observe and learn from consequences or remeasuring, and modifying and applying change. Now let's start with the PDSA cycle. The first step is plan. This involves proposing change idea and how it will be tested. It involves defining the problem, identifying causes and alternatives, and developing strategies to improve care. COVID-19 affected different people in various ways. Some have mild symptoms, others progress to severe illness. Symptoms may appear initially as flu-like symptoms: fever, chills, cough, body aches. But it can easily progress to shortness of breath and trouble breathing, which indicates lung damage. Once the lungs sustain a widespread injury, it diminishes the lung's ability to bring oxygen to the vital organs of the body. Fluid starts to accumulate in the lungs and reduce the blood oxygen to dangerously low levels. This condition is called acute respiratory distress syndrome, or ARDS. The treatment is supplemental oxygen therapy, and most will be placed on a mechanical ventilator to help them breathe. With treatment, an estimated 60 to 70% of those who have ARDS will survive. These patients need to be intubated and be placed on a ventilator and admitted to ICU. This is where we see the problem. Using a fishbone diagram or root cause analysis, we illustrate the contributing factors or the backbones that led to the problem. Identified causes of increased mortality among COVID patients are: Number 1, shortage of ventilator. Number 2, ICUs are overwhelmed in the number of patients needing ventilator care. Number 3, shortage of healthcare staff to care for these patients. Number 4, ventilator-related complications. And number 5, variance in treatment protocol. After defining the problem and identifying the causes that led to the problem, we now develop strategies to improve care. To qualify possible solutions to the problem, it must answer the Institute of Medicine's aims. It must be safe, timely, efficient, equitable, effective, and patient-centered, and it must be evidence-based. Solutions to delay intubation while waiting for available bed or available ventilators are the use of non-invasive ventilation, high-flow nasal cannula, and awake-prone positioning. Non-invasive ventilation and high-flow nasal cannula have been used in mild to moderate acute respiratory distress syndrome and may reduce the need for invasive mechanical ventilation. But these methods of oxygen delivery are associated with high aerosol generation and can create aerosolization of high viral loads that can increase risk to healthcare workers. Awake-prone positioning is the better option with minimal danger. Prone positioning is the technique of positioning the patient with compromised respiratory function from their back to their stomach. Awake-prone positioning is an innovative approach to manage the excess pressures of fluid around the lungs. By positioning the patient face down on their stomach, the dorsal alveoli are relieved of pressure. This promotes recruitment of lung tissue and improves oxygenation. This is a low-risk, low-cost approach to treat acute respiratory distress syndrome in afflicted COVID patients. Using awake-prone positioning in clinical practice can also reduce the need for mechanical ventilators and reduce the need for ICU care. Benefits to patients include reduce hypoxemia, improve ventilation perfusion matching, reduce intrapulmonary shunt, reversal of atelectasis, and improve secretion clearance. The benefits of awake-prone positioning to the healthcare system includes reduction in the need of limited resources, reduction in ventilator-related complications, reduction in days of hospital confinement, active involvement of patient with their self-care, and improvement of quality and safety in healthcare delivery. The patients that will benefit most on these treatments are those conscious, cooperative, alert COVID patients who can communicate their needs, patients who are able to adjust their own position with minimal assistance, patients with pulse oximetry reading of less than 94% on room air, and breathing more than 22 breaths per minute, using oxygen supplements such as nasal prongs, non-rebreather mask, high-flow nasal cannula, and non-invasive ventilation. The contraindication for awake-prone positionings are history of spinal or pelvic instability, increased intracranial pressure, pregnancy in the second and third trimester, hemodynamically unstable patients such as those who have arrhythmias, recent abdominal and chest injury or surgery, compromised airways, or patients who are nearing respiratory exhaustion, needing to be immediately intubated, and those patients who are uncooperative with altered level of consciousness. And finally, we have to incorporate the awake-prone positioning care initiative to the PDSA cycle. Our plan is for awake-prone positioning to be practiced in all COVID patients with mild to moderate ARDS. In order to implement this program, we have to educate the staff involved, conduct a pilot case for awake-prone positioning. After the conduction of pilot cases, we analyze the results. We measure the effectiveness and check for complications, and then make some changes. Once the changes has been made, we implement the process hospital-wide, and then we can add more educational sessions. Thank you for watching this video.